0.4. Okay, that's your order. Now, if someone can give me a forceps, we'll start clearing this bone and clear everything. We can make a small hole in the ground.
हर मिनट ऐसे कैसे रहता हूँ मिला मिनट
Window is to enter the frontal directly. So when you make a hole here and going straight, but that's visible usually when you have a revision case, you have stenosis in this area there. So I'm sorry, but I've only got a forceps and no divider, so we may have to take some mucosa for us to clear this area. Okay? But now you have a good, very good view of the frontal sinus. Okay, sorry, I think I'll take a closer so that you get a better view. Not something like that. Okay. Yeah, maybe that's more. So there is some punch. Okay, so is this clear? Frontal sinus? This is the supraorbital. There is still some bone above that between the frontal and the supraorbital, which we can take out, but I can't reach it. So I would like to check this bone out and see if we can remove this bone. So that will then widen my frontal sinus. Okay? Now you see we have a really nice good frontal sinus. So these are all the cells that are blocking. So the type 1 cell. Okay, we have agar cell, type 1 cell, or whatever cell. And now you have a really good frontal sinus. I can actually go inside with my scope and show you lateral and medial. Okay? Below that is the supraorbital.
Entered matter.
This is all supraorbital, which is very well pneumatized. And under the supraorbital is the anterior artery. It's a very low lying artery. Can you see?
Yes.
Hello, auditorium.
The audience is there, so many audience is there.
Yeah, we have the problem. Can you see this?
Yes, sir. Yes, sir.
Very low lying anterior point. Okay, it's out of the bone canal.
Yes, sir.
So this is standard. Frontal, 1 cell below, which may be supraorbital or suprabulbar. Below that is always anterior point. If I put my elevator here and push down, I'm going to be pushing on the artery, which is normally in a canal, and so it will not break. Okay, in this case it's resistant, and we would have seen that on the scan. Below that now is all that ethmoid sinus, which let's open up fully now the bulla and see where we are. Okay? So let's change the scope to 0. How to use any angle scope. So we have a question on how to use the scope. So let me go back to the 17. So when you use an angle scope, suppose I want to look into the maxillary sinus. Okay? A big mistake what people make is to point the scope straight away towards the maxilla and try and go in. Okay, no. Always have the scope looking upward. Have the scope looking upward first so that you can see your anatomy. This. You are rotating your whole picture. Okay? Only the cable rotates. The camera does not rotate. Only the cable rotates, so you don't use orientation. Oh my god. This is the inferior orbital nerve. Also very low. Look how low the inferior orbital nerve is. Amazing. Can you see this?
Yes, sir.
And then it's dividing into the alveolar branches. Wow. If we have time, I'm going to show you some fantastic anatomy of the pterygopalatine.
Okay, sir.
Okay, because this is a beautiful specimen, just beautiful to show you. Okay, so that's how, and then you want to come out again, rotate and upward, and then come out going downward. Okay, if you want to go into the maxilla, don't go towards the maxilla straight away. Go away from the maxilla and then slide inside. This is how we use an angle scope. If you have to use an instrument with it, give me that protraction. Then again it's very tricky, so try and come out a little bit with the scope, see your instrument and then follow the instrument in. Okay? Otherwise you'll be hitting things and you'll be causing trauma. Let's go back to the zero. Oh wow, this is very exciting. This cadaver is beautiful. Okay, so this is ground lamella. Okay, so I can go into the retrobulbar recess. Okay, here, behind the bulla and come forward. So I can take out the whole bulla in one shot. Okay, so that's the whole bulla. So let's take out that bulla. Okay, so what you have now after the ethmoidectomy is over is you have the middle turbinate turning laterally. Do you appreciate that?
Yes, sir.
Middle turbinate turning laterally, so that forms your ground lamella.
Yes, sir. Yes, sir.
If I go through the ground lamella now, through this, I'm in the posterior ethmoid. Okay? So let's go in. Normally you want to go in infero immediately. I don't have a sharp instrument. But I'll have to take out this mucosa to show you where I am. Okay, so we are in the posterior ethmoid. So let's clear this. Now once you enter the posterior ethmoid through the ground lamella, you should have a view of the superior turbinate to confirm that you are in the ground lamella. Like you have the middle turbinate ground lamella, you have a superior turbinate ground lamella. So this will then form my superior turbinate ground lamella. And if I follow it upward here, okay, it should take me towards my superior turbinate. Okay? Can you see this now?
Yes.
Superior turbinate. Okay? The structure at the back is the superior turbinate. Middle turbinate, superior turbinate. Are we okay?
Yes, sir.
Now we still have some cells here, right? We have skull base here. We have some cells here. So let's open up these cells. You can use anything you want because I know for sure it's low. So I'm not sure. The live patient I will not do this, of course. We'll use a curette or a debrider to gently take the bone away. So here again I have a cell and we want to open up this whole area nicely. Please understand, in a live patient we would do this with a cutting instrument and save all this mucosa, right? Here I'm forced to take the mucosa because I don't have debrider or good sharp cutting instruments. So let's take this mucosa away. Please clean this. I'm doing that. Give me a pose for me.
After.
Okay. Just clean the upper and keep it ready. So let's take this mucosa away. Now you can see again another amazing sight, right?
Posterior ethmoid artery.
Posterior ethmoid artery. Also low lying. So the posterior ethmoid artery corresponds very closely. Give me an upward view cut. Upward view cut.
It's more horizontal than the first one.
Yeah, what does the posterior ethmoid artery correspond very closely with? So now you see this is the medial cribriform. Can you see this very thin bone?
Yes, sir.
Okay, this is all lateral cribriform. Okay, lateral cribriform. So this is the thinnest point of the skull base, where the anterior ethmoid artery enters into the skull base, into the cribriform. This is your point of getting CSFTs, most common. Okay, also all this area. And we can afterwards, if we have time, we can create a link and show you. Okay, this is all orbit on this side. And let's clear this mucosa, ethmoid. Right, so the question was what does it correspond to? Elevator. Elevator. Where's that elevator? Elevator first. Yes, sir. Next to it. Yeah, yes, sir. So the posterior ethmoid is a landmark for me for orbital apex. So I'm very close to orbital apex. Okay. So this is orbital apex, which then is an indicator landmark for the sphenoid sinus. So from the posterior ethmoid, I am touching distance of the sphenoid sinus. How do I be sure? I have to be inferolateral to the orbital apex, behind the optic nerve. I'm in the inferior half of the inferior half of the superior turbinate. That's superior turbinate. So I want to be inferior half. Okay? And maxillary sinus upper wall. If I draw a straight line from that ostium, what is above that line is the ethmoid, what is below that line is the sphenoid. Because this takes you to the orbital apex. Okay? Are we clear in the audience?
Yes, sir.
Okay.
Repeat, sir. Please repeat it again.
Repeat it again, sir.
Okay, there are landmarks for the sphenoid. Coronal arch, 1.5 centimeters above. Superior turbinate, inferior half. Orbital apex, inferomedial. Posterior ethmoid artery, posterior inferior. Maxillary sinus ostium, upper part is the floor of the orbit. Draw a line back, it's into orbital apex. Above that is ethmoid, below that is sphenoid. Are we good?
Okay.
So now if I have to open the sphenoid in a lateral approach from the orbital apex, I want to come inferomedial. Right? So somewhere in this area I have to enter. Okay? To enter into the sphenoid. This is one option. Second option is to cut the superior turbinate and see the ostium in this area. Okay? Third option is to come medially, locate the ostium by lateralizing the turbinates. Okay? Third option. So this is the medial approach. This is the intermediate approach. This is the lateral approach. Is there any other approach? Hello? Anybody? One more approach?
That's from Koana. As a friends.
Exactly. Transeptal. You can just follow the septum back in. Right? Septum will end on the rostrum. So I'm cutting the superior turbinate. So then we can now do a intermediate approach.
Which approach is safe, no?
All are safe. Safest is a medial approach because the sphenoid sinus is the only ostium you can see without doing any surgery. So for me, the easiest sinus to operate upon is the sphenoid sinus, not the maxillary. Sphenoid sinus. Right? If I go in from here, move this turbinate, move that turbinate, I'm in the sphenoid sinus. Straight away, no problems. Clear?
Yes, sir.
I'll just show you this. Can someone just reach into my pocket and pick up my phone? That phone is open. Yeah, so, one second. Okay, so this is the easiest approach to get to the sphenoid. But this destabilizes the middle turbinate. And normally in FESS you don't want to destabilize this turbinate or push it immediately. So we do this. Who's speaking? Just give me the name of who's speaking. Keep it with you. Keep it with you. Look at. Okay, so let's remove the last bit of that thing. So all the approaches are safe. Intermediate is also safe. The lateral approach takes a little getting used to. Okay? Little approach getting used to. But you see, if I had gone in laterally, I was in the exact same spot as I was in the sphenoid. But I would have come in with the lateral approach. Clear? So this is my lateral approach. Punch.
Carry some.
There is a punch. So we can go down and widen the sphenoid a bit. In this part it's safe to widen the sphenoid. And then we can go up. As long as you know where the optic nerve is, you are okay to go even superiorly or laterally. So I'm going towards the posterior ethmoid.
What is maxillary line, sir?
That's what I showed you, the horizontal line. Now there are two lines. One is vertical line for the basoacromial duct, and one is a horizontal line, what I showed you for the sphenoid landmark. Maxilla, draw a line back below that. You see where it takes you? Orbital apex, optic nerve. So above that will be ethmoid, below that will be sphenoid. Now we have a very beautiful view inside. Carotid artery, optic nerve, posterior ethmoid. Okay? Posterior ethmoid is also opposite canal. Punch. Let's make it wider. Yeah, always you make it wider. So now we are getting the sphenoid really open. Okay, that's the cella. So that's
Optic nerve.
a little more.
সাদা সাদা সাদার পরে লাল না সেটি
I'm so happy you didn't give this cadaver to Sunil.
এইভাবে অরবিটে ঢুকছে
Because then you wouldn't have seen all these lines and angles.
এই যে সাদা সাদাটা আর অপটিক এইভাবে এসে ল্যাটারালি অরবিটে ঢুকছে
I'm trying to
নিচে
push
লাল
across the
দিতেছে
midline.
সাদার নিচে এটা
Just
হচ্ছে
to
মানে
try and
ক্যারোটিড
give you
এরিয়া
a good view of the cella.
Sir, how much extent we need to open up the sphenoid also?
No, now I'm going for hand.
সাদার নিচে
We don't need to do
মাঝখানে লাল
this.
এটা ক্যামেরা সাইনাসের লাল
I'm just trying to avoid going to the other side because of the gradient. So now we have a full view of the cella, and if I can take a little bit of this intersphenoid, I should be able to show you the right carotid also. Okay?
How is this semi-full?
So this is now cella, carotid, below that is the clival carotid, this is optic nerve, tuberculum, planum. On the other side we have a little bit of bone yet of the intersphenoid. So the intersphenoid septum is still intact, so I can't show you more than this. But I want to go down so that I can show you the clival carotid a little better. Let's put this out. Punch. Yeah, but I mean, everything I need to show you was on this side. So you can see almost a full cell on this side. So I'd rather use my time to show you. So we are just going inferiorly towards the sphenoid floor. Okay. So now we can see very clearly the entire carotid. So let's trace the carotid. This at the bottom, you see this little red bulge. This is the clival carotid. This will then turn laterally, come up here and suddenly turn laterally and anteriorly and form the cavernous part of the carotid. And this last part is the clinoidal part of the carotid in front of the optic nerve. Okay, this is the sella and this is the clivus below. Everyone's good with this?
Yes, sir.
Now we are going to take out this glucosa and see all this anatomy even better. Sorry? What was the question?
They will be asked for fracture.
And you can see that this carotid is going to be a little adhesive.
এখানে শার্প কোনো কিছু দিয়ে
It's just a beautiful specimen.
টেকিং করে হবে
Okay, this is sella. Let's get our upward forceps, please.
Sir,
Haji?
On lateral recess of the sphenoid sinus, what is the way to regain that area?
Sure. Now, did the rhinoplasty side have some osteotomes and hammer?
Yeah, yes.
Well, I will need that. Clival carotid, cavernous carotid, sphenoidal carotid, optic nerve. Sorry, I'm going to start again. Very good. Yes. Okay. So carotid artery, you can see some of the bone is missing there, right? Okay, so it would be nice to show you carotid as well. And then you have this clivus, sella, cavernous carotid, optic nerve, plenum, posterior ethmoid artery, skull base, skull base, skull base, anterior ethmoid artery, and frontal sinus above. Okay? Even with a 0 degree, I can show you all of these things. Maxillary sinus here. Okay. Now, FESS is over. What is the next thing that you want me to show you? So what we'll do is, time permitting, we'll do pterygopalatine, we'll do an optic nerve, we'll do an optic nerve, and we can do a paracellular dissection of the carotid. Okay?
Transcavernous approach and all the.
So somebody please keep an eye on the time. Okay, so let's start with. I have no problem. Okay, let's go.
So we are entering it so much.
Okay, video discussion. Okay, so now if you look in that elevator, this is just beautiful.
sir, excuse me, sir.
Yeah.
Odoculus show pituitary gland and spinopalatal artery ligation.
Yeah, so I'm showing you sphenopalatine. This is the back end of the maxilla. Okay? This is the back end. So this is the line for the internal maxillary artery. Can you see this? If I come medially, this is the middle turbinate attachment. I elevate this mucosa, which I've already elevated. I see a ridge of bone. This is the crista ethmoidalis. Just behind the crista is the sphenopalatine. Can you see what I'm doing? I'm stretching it. Can you see the artery coming out?
Yeah.
Yes, sir.
One branch here, one branch here.
Yes.
Branches.
This is sphenopalatine.
Yes.
We have more
yes.
branches. Okay? Now you see, this is all sphenopalatine. So this is the pterygopalatine fossa. Okay? Now let's open up the pterygopalatine fossa. So I'm going to just take out this bone a bit, so we can see clearly into the maxilla. And I need to take the mucosa off from the posterior maxillary wall. Okay? Super. So I'm just taking all this mucosa off so that we can go right up to the infratemporal fossa. You can already see the line for the internal maxillary artery. Okay? Give me the upward pointer. Okay, so this is all done. We will take out this mucosa on top.
Annexes are fairly visual here, including its branches.
Yeah, I'm going to see it in the raw. Okay. So this is now orbital floor. Okay? I need to come a little more anterior to show you the punch. The infraorbital nerve. So I'm going to punch this bone off between the nasolacrimal and the maxilla. I don't need it. You will see at the moment. You will understand better what I'm doing. Okay, give me upward point. So let's take out that piece of bone which we are using. For those who like to cauterize for allergic rhinitis. Okay? So the nerve itself you see with the vessel. You don't see the nerve directly. You follow the vessel, the nerve follows the vessel. Scissor or throat, whatever you want. Right, so let's just, instead of taking on the whole inferior turbinate, I'm just going to make a cut here. Okay? So now we are going towards the eustachian tube. So now I have my medial pterygoid exposed. Clear? Okay. At some point we will sacrifice the middle turbinate for you to see better. Give me a punch. Now, if I want to open up the pterygopalatine, I can take my caricid punch and it's in the pterygopalatine fossa. I can punch. One, pterygopalatine is open. Let's punch a little more and we get into the maxillary fissure. Okay? We can take out that one. And this bone will help us to even trace the infraorbital nerve and for me to show you the
medial pterygoid. Maxilla, both of the maxilla. And I put it.
okay. Okay.
অরবিটাল ফ্লোরে কোনটা থাকে?
So now
ম্যাক্সিলারি পার্ট থাকে না,
this is your
এটা
internal maxillary artery.
ফোসা
Maxillary
ফোসাতে
fissure.
চলে গেল।
Approximately here is the lateral pterygoid. So lateral to that, we are going to go to the infratemporal fossa. Okay. When I see the infraorbital nerve, from lateral to the infraorbital nerve, and I'm in the infratemporal fossa. So let's remove a little bit more of this board. The all back wall of the
অরবিটাল প্রসেস পালাটাইন
Inferiorly, we are going to follow the internal maxillary into the descending palatal.
তিনটা বংশী কানেকশন
Okay.
প্যালাটাইন বল
So,
ম্যাক্সিলারি
we are now at the orbit.
দিয়ে একটা ফিশার তৈরি করে
We have
Infraorbital fissure.
Here now is going to be the descending palatal. I need the osteotomy now. So to break this bone, I need an osteotomy. Zero. Yeah, give that. Sorry, somebody will do that. Up, and I tell you. Okay. This one. No.
জোরে
Don't do it.
সপ্তাহ
So we are taking out this bone in front of the descending palatal. Can you see now the artery? Yes. Very clear.
ইনজেকশন দিই
Okay, let's chart this bone. Now.
প্যালাটাইন পুরানো
Let's follow the descending palatine can also take you to the internal maxillary. So the sphenopalatine is here, can take you to maxillary, descending palatine can take you to internal maxillary. Both these are the last two branches, right? Okay. So I'm going to just fracture the osteotomy. Fracture. Okay. Check. Okay. Gentle, gentle, gentle. Okay. 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 Alright.
বিয়ের সময় করছিলাম
So this is the bone over the infratemporal fossa and the IMA. So now our whole area of infratemporal fossa, fissure, pterygopalatine is open. Okay? So let's find the IMA. A periosteum is still intact. Okay? So we need to open up the periosteum. Oh, sharp. Like a sickle knife.
সিম্পল লাইন পাস
Good. Put that in the way. Throw it away. Okay, so this is a periosteum. Okay? So we need to elevate this periosteum. If you want to see the artery. Artery below the periosteum and fat. your bipolar ready as your muscular clips ready.
Muscular clips.
Okay, so that's your internal maxillary artery. Okay, lovely. Can I have a scissor? Okay, break it.
Hey, audience cool. Audience cool.
Okay, so now you can see very clearly the whole internal maxillary artery. It's a little tortuous artery. Okay, and it goes down and forms a descending palatine, and here it will come up and open into the sphenopalatine. You have to go lateral to the tumor, so it just depends on the tumor size. Yeah, you have to go lateral to the tumor. Okay, so you want to then separate the artery
To the tumor, other like
and then be able to ligate it. Okay? So this is all fat. And now you have the artery, which you can separate and ligate. Excellent. Are we clear with that?
Biomass.
So now, if I go up a little bit, let's go up. Give me that 70 scope. I just want to clarify where my internal no, please catch. That brings me to the nerve. Yeah, let's take a punch. Oh, osteotomy. Okay. Let's go.
Ini akan nanti dia.
So I think we are good enough here. I don't think we need to do more. Let's go back to the zero and hope it's working. Let us open up this.
তোমারটাও তো পড়ে গেছিল তোমারটা গেছে তো আমারটা আজকে দেখা যায় না স্টোর স্কুলে বসে আছে
So you can imagine whatever happened. Now you see we are taking out the maxillary process, which is the front part or the back part of the maxilla, front part of the spinal, towards the carotid. Clear? Yes. No, bring the bottle. It was not bottle anyway. This is see what I want to do. So now we have that intraorbital nerve coming here, and this is going to take us to the foramen rotundum. Okay?
Yes.
Inferiorly, I want to see the median nerve. So this is medial pterygoid. This is floor of the sphenoid. So I will need to cut this part off for us to see it clearly. Let's just dissect this. Okay. Maybe if I take this off, I can see. Okay, this is a branch, and this is an interesting branch. What branch is this? See this branch? This is my posterior branch that feeds the hadad flap.
Yes.
Okay? My hadad flap is based on this artery. This is a posterior branch of the sphenopalatine. Okay. So now I'm going to just sacrifice my sphenopalatine so that I can see beyond it through cut. Okay. So, in the medial part now, if you come from here, you have the palatovagina. Okay? Palatovagina. Here. Just medial to the palatovagina, or just lateral to the palatovagina, is going to be the median nerve. So I want to take out the inferior part of that sphenoid bone off.
জোরে ফোর্স দিক অনেক মোটা
Hold the head, somebody hold the head. Hold the guys, easy, go get easy. It's my loss. Okay. Now, come on. Come on. Come on. Now, just take this bone off. This is now going to be towards the medial. Okay? I'll show you in a second. This is the medial pterygoid. This goes towards the palatovagina. Okay, and the median nerve will be straight. See this? Okay, give me that cotton. Okay, this is the median now. Can you see this canal?
This
Okay,
side.
clear?
Yes, clear.
Yes.
Median. This is palatovagina. Okay, so we have a C. Once we get palatovagina, we get median, and if I follow that median up, I'm going to see the rotundum. Rotundum will coincide with the infraorbital nerve coming from here. Right? See this hole here? This is now foramen rotundum. Can you see this? Okay? When my instrument just went in. So I'm opening up the foramen rotundum. Okay. So it forms a C. Rotundum, median, and palatovagina. This is the spheno. Sorry, I didn't hear. This is the sphenopalatine ganglion. Okay, so from the sphenopalatine ganglion, what are the nerve connections? Pharyngeal nerve, median nerve, V2 going posteriorly, infraorbital nerve coming anteriorly, and the palatine nerves, greater and lesser, coming, you can see behind me, descending palatine. I don't know if you can see these nerves. Can you see the descending palatine nerves now? the greater and lesser palatine nerves. See these two? Okay?
Yes.
These are the nerves. Okay. So, we can then elevate this and we can just cut it off here. Give me a low cut. So, I'm just going to cut off that pseudopalatine ganglion. The ganglion is all ganglion. Okay, you don't see it obviously like that, but it's not part of the ganglion. Okay. So now you see the median better. Okay? Median and V2 going in here. Okay? Can you see foramen rotundum now clearly?
Yes.
This is your canal. Okay? The rotundum is a landmark for the mid-clivus. It takes you to the mid-clivus part of the carotid. This is your third cranial nerve area. Okay? Oh, sorry, not third area, or V2. And your median nerve will take you to the base of the clival carotid and the junction of the petrous carotid. So this is foramen basal. This is where your clival carotid starts. Give me a point process. So this is your pterygopalatine anatomy. Now if you want, I can show you the carotid anatomy. Do we have time?
Yes, sir.
Give me a straight.
Straight.
So for me to show you anatomy of carotid, I need to open up this median canal.
Good. Yes.
Head. Somebody hold their head. So this is all medial pterygoid.
Base.
Yeah, what we call the pterygoid wedge. So usually you do all this with the drill. Here we don't have the drills. Okay, so let's take out this pterygoid wedge. The medial pterygoid here, we have the median nerve here. Let's take this part out. Okay, let's go.
How median nerve is formed?
Okay. What I say. Okay.
Get the wings. I'll get the wings. Brain. Middle brain and first. Karena sama si Jawan masih.
Okay, give me a corner. So we're making good progress.
আমার মার যুগ ছিল যে মালগুলো বুঝে
So this is all the bone. Now we have only little bone left over the liable part of the carotid and over the optic nerve. So let me take out that optic nerve bone first. So this is all posterior orbit. This is optic nerve. So at the annulus of zinc, the bone can be at its hardest, and then it gets a little thinner. You are optic nerve decompression. This is an optic nerve decompression. So you all know lateral OCR, no? What is MOCR? The medial optical disease, right? So this is now the MOCR. This is the lateral OCR. Okay? And this is carotid arteries. This is tubercular.
Carrison.
So the tubercular is usually harder bone, thicker bone, and so requires a little more force or drilling to take out. So that's now our tubercular one. So our optic nerve has already gone intraarticular. Okay, optic nerve.
Yeah.
So I'm going to open up a little bit more of the bone here, so I can also show you the osteotome, the anterior ethmoid arteries. Sorry, the anterior cerebral arteries. Okay, touch. Oh, sorry. Okay. Then, so this is bone over the planar. Okay, this is touch. So here will come the area for the intercavernous sinus, and posteriorly will come the optic chiasm. All of this we are going to see once we incise the dura. Is there somebody still there in the audience? Or is it shut down?
Excellent circulating.
Okay, that bone over the planar. And in another 5 minutes, we'll be able to open everything and see all the anatomy. So the last bit is the clival carotid, the osteotomy again. Okay.
Cross.
Economic forceps, let's clean up everything and then we open. Guys, thank you for being patient. I assure you it is worth it.
ব্যাকলাইভাল ক্যারোটিড, এটা হলো ক্যাভার্নাস ক্যারোটিড, ঠিক আছে। এরপরে ক্যাভার্নাসের এখানে এসে একটা গুলটুলি পাবে, ক্যাভার্নাসের থেকেও আবার ওই পিছন দিকে চলে যায়, এটা হলো তোমার পোস্টেরিয়র জেনু বলে,
এরকম করে।
হ্যাঁ পিছনে যায় এখান থেকে একটা তো
ওইটাই বলতেছি, এইভাবে ওইটাই এখানে কুণ্ডলি পাকাইছে।
কুণ্ডলি পাকায়নি, এই পর্যন্ত এর এক্সটেনশন, এরপরেও পিছন দিকে গেছে যে, তারপর হলো এন্টার সেলুলার,
এটা তাহলে কি ক্যাভার্নাস সাইনাসের অংশ না?
এটা হলো পিটুইটারি
পিটুইটারি, সরি, আচ্ছা।
কোনটা গ্ল্যান্ড কোনটা?
এটা পিটুইটারি
উপরটা আছে, এটা হলো তো প্যারাসিজাইটাল এক্সটেনশন কোন পর্যন্ত গেছে। উপরে আমাদের কি আছে? এন্টারএথময়েড আর্টারি না, এন্টারএথময়েড আর্টারি, পোস্টেরিয়র আর্টারি, দিস ইজ দ্য ট্রান্সক্রিবিফর্ম এরিয়া। পোস্টেরিয়র টু এইটুকখানে, দিস ইজ দ্য প্লেনাম স্পেনোইডেলি, ঠিক আছে। প্লেনামের থেকে এই যে অপটিক কাইজমা যতক্ষণ থাকে, দিস ইজ দ্য টিউবারকুলার সেলিং, দিস ইজ দ্য সেলাটার্সি, এই সেলার নিচে হলো ক্লাইভাস, ঠিক আছে। তাহলে এই হলো তো পুরো স্যাজাইটাল সেকশন গেল।
স্প্লেনাম যেটা বলতেছেন,
প্লেনাম না প্লেনাম,
এটা কিসের পার্ট?
স্পেনোইড, লেসার উইং অফ স্পেনোইড।
When we open the parcel, you should see everything inside, not through a little peephole. Okay.
দুইটার ইমপ্রেশন আলাদা, এটা একটু লাল লাল, ওটা একদম সাদা, এইগুলো
পিটুইটারি আমরা ওই ইয়েতে দেখছিলাম ট্রান্সফ্রন্টাল অ্যাপ্রোচ, ট্রান্সক্রিবিফর্ম অ্যাপ্রোচ, তারপর তো হলো ট্রান্সপ্লেনাম, ট্রান্সটিউবারকুলার টিউবার, ট্রান্সসেলার, ট্রান্সক্লাভার, সম্পূর্ণ জায়গা।
Above us, we're going to be the
brain plane.
with the anterior cerebral. You see here, the anterior cerebral.
ব্রেন
One side of the anterior cerebral. Okay, give me a call now. Let's see if I can show you. This is the pituitary stalk. These are the tissue arteries. You see this coming across. These are all the branches of that hypophyseal. So it's quite a dense. You see the stalk here. So the horizon now. This is the loss of cell. So with this, below that you will see the digital artery.
Select.
So there's some fibers in that. This is the loss of cell. white vein is here.
Yes.
Okay, so this is big brain.
What vertical?
Your brain. This is the stalk. This is the skin running down. This is the pituitary stalk. These are the branches of the hypothalamus. This is not the full optic nerve on this side. We have opened up the sheath of the optic nerve.
chiasma দেখেন ওই optic chiasma
Now, lastly, to show you is the cranial nerve lateral cavernous sinus. So, for that, I have to move the carotid to this side. Give me the knife. Optic